talking about heartburn. Is that something you guys have experienced already? Yeah. So that is contents of our stomach coming back up the esophagus. Does not feel good. So one of the things is just overeating. When the stomach is too full, it's trying to go back up. We want to avoid that. There are also foods that can trigger that experience too. It's like spicy foods, acidic, those high-fat foods we were talking about, especially fried foods, saturated fats. Citrus can be irritating. But also carbonated beverages, because we're consuming that extra, those bubbles. But also things like chewing gum or drinking through straws. You're swallowing that air that can be trying to come back up too. One thing we want to pay attention to with that is if we start having trouble swallowing. That's always something you want to talk to your doctor about. But staying upright after your meals, avoiding really tight clothes, can be other ways to manage that. Osteoporosis, this thinning of our bones, so that the steroids can make us not absorb our calcium or our vitamin D as efficiently. So we want to make sure that we're getting enough of it. Paying attention to that dairy that a lot of people aren't getting enough, but also leafy greens, other things like that. But nutrition isn't the only component. It's always lifestyle as well, so making sure we're getting enough activity to put some stress on the bones to keep them strong. Again, avoiding that tobacco and limiting our alcohol. So here are some of those sources of calcium. Those chia seeds that have the omega-3 fatty acids, some good broccoli, orange juice, the fish, almonds. Good. But vitamin D is also important with the calcium too. You need vitamin D to absorb that, but we want to kind of limit our sun exposure in this case. So paying attention to our good food sources of vitamin D. Again, those fatty fish. Mushrooms are an interesting one. Now they'll use special lights as they're growing mushrooms that can help increase the vitamin D content in the mushrooms. That's something to kind of pay attention to. But this might be a situation where we want to supplement vitamin D to make sure that we're getting enough and supporting our bone health. Another situation where we might want to have a supplement is if we have some anemia. If we're losing some blood through our GI tract or not making enough blood cells. There are different types of iron that we can get through our food. So we have our heme iron from our meat sources that are more easily absorbed, but also our plant sources too, leafy greens, nuts and seeds, beans. We want to make sure that we're taking those with vitamin C too, which we'll get with our fruit. So if we're getting our fruits and vegetables at every meal, we're doing a good job there. But it's important to pay attention to what kind of supplements we're choosing. So a USP is a organization that verifies the supplements to make sure that it has what it says it has and nothing extra. So if we're looking at a supplement, I would not do anything more than a daily multivitamin unless you have a deficiency, unless you've talked to your doctor and decided that vitamin D is a good thing for you, or you need iron or something like that. Because sometimes supplements can have ingredients that they don't claim on the label, and that could potentially be alfalfa that we're trying to avoid. So I wouldn't do any herbal supplements that you are unfamiliar with. And also avoiding anything that advertises that boost in immune function. We're not trying to get any extra immune function. So no echinacea. Turmeric is another big one right now that people are interested in. We don't want to be supplementing with anything like that. It's okay to use some in your food as flavoring, seasoning, but not taking it as a supplement. And if you are taking a supplement, always make sure that your doctor knows. So again, for that USP, it's identifying that it has what it says it has in the potency that it claims to have and not having any adulterants in it, nothing else in there. So another thing we might commonly see with medications is dry mouth. Is that something you guys experience? So there's some ways that we can deal with dry mouth. other than just drinking constantly. Sucking on ice chips, that's good too. That cold can feel more refreshing if you're feeling really dry. Another one that I really like to do is putting fruit in the freezer, something like grapes or blueberries, even chunks of melons or bananas. You can suck on those. There are a lot of products out there that you can get, things like saliva substitutes, little mouth moisturizers, little tabs that you can put on your gums that'll melt and coat your mouth. But also using a humidifier at home, especially at night when you're sleeping, can help keep you more moist. One of the big concerns with having dry mouth is that it can increase your risk for cavities, which can then affect your ability to eat, chew hard foods, things like that. So we want to take good care of our teeth. Continuing to brush and floss every day. If flossing becomes difficult, there are other tools that you can use too. Over here, the Sonicare Air Flosser. It helps by just shooting air in between your teeth to get things out there instead of the floss. Making sure we're using fluoride in an alcohol-free mouthwash. A mouthwash that has alcohol can irritate your mouth even more. A lot of people will start using candies or something like that when they have dry mouth. And if we're adding a lot of sugar that way, that can also increase our risk for cavities. So one thing to keep our eye open for is xylitol. It's one of the newer artificial sweeteners. You can also find it in the baking aisle if you were doing any cooking at home. You can cook with xylitol too. But it's now common for gums or mints to be sweetened with xylitol. That can help to balance the pH of our mouth and reduce our risk for those cavities. And always avoid tobacco. But in addition to nutrition, there's always the other lifestyle components. Nutrition is only one aspect of lifestyle. So making sure that we're physically active on a regular basis. It's going to, again, strengthen those bones, but also keep our muscles strong for good mobility and flexibility. It's also going to help promote our sense of well-being. Unfortunately, fatigue can be kind of this negative feedback loop. We're tired, we don't want to do anything, so we don't do anything, and we're more tired. It just spirals on and on. So it doesn't have to mean going to the gym. It doesn't have to mean lifting weights or doing anything like that, but getting out and moving your body. Going for a walk, moseying around in the garden, or just stretching in the living room. Start slow, build up. We're not trying to run a marathon. So pace yourself and plan breaks in your physical activity. But also listen to your body. If it does feel injured, pay attention. Don't overuse your joints if they're inflamed. Make sure to use warm and cold ice in the warm bath. I see a couple people writing. I'm just going to hold on a second. And another component is that sleep. Insomnia can be an issue. We want to build some good sleep habits, which can mean a good sleep routine. Getting into bed at the same time each night, trying to wake up at the same time each morning, so our body kind of has an idea of what to expect. But creating a nighttime ritual before you get into bed, things like unplugging from the computer, getting away from that cell phone, sitting down with a book and a cup of tea, just winding down for the night. And also limiting other activities in the bedroom. Train your body so that it recognizes bed equals sleep, not bed equals Netflix. Okay, so we did it. We made it through all that material. So here's some resources I used. If you guys haven't heard of it, the Lupus book is a really great resource, and it is available through the Seattle Public Library here. You can check it out and read it. And then, of course, the foundation has the means website. Okay.
Thank you, Megan, for your great presentation. And at this time, I'd like to call all the presenters up for some Q&A.
Give us a minute to set up the chairs real quick.
Right now, I have also been very I was not in 6 weeks ago. I was at the heart failure clinic.
All right, so we have obviously a wealth of information and resources here in the room with us. So what I'd like to do is open up the floor for questions. I will ask that if you can make your questions a little bit more general in nature, you will have an opportunity to ask more specific questions, personal questions during the breakout session. So if you can kind of keep the questions more general, that would be great. So let's start with Marie.
Well, my question is about the promise for therapies coming out if you look out over the horizon 10 to 20 years. So it's really for Dr. Carlin and Dr. Sarah Soletti. Dr. Sarah Soletti, you mentioned this regulatory T cells and this IL-2 thing. You know, at what point might that become more standard and help a broader set of people? Dr. Carlin, you mentioned interferon trials looking more promising on those patients. So could you like kind of look out 10 to 20 years and say what you think are likely, you know, are there any blockbusters maybe coming along potentially or what?
Yeah, so I can talk a little bit about the IL-2. So right now, those trials are happening in France and in China. So nothing is currently going on in the U.S. And Dr. Carlin concurred that at the rheumatology meeting, there was no discussion about a trial going on in the U.S. So I think that's one of the ones that's going to be more long-term. And I think for any of these therapies, you know, they're not a panacea in terms of who's going to benefit from them, and that's where that, you know, trying to target them to the right patient comes in.
So thank you, because that's a good, I meant to plug something. So we are now part of what's called Lucent, which is the Lupus Clinical Investigators Network, which is out of New York. And I think it's about 50 sites or whatever. So, and we also are in some discussion with some other drug manufacturers, Biogen, and some of the others. So we hope to have some trials coming, at least phase 3 trials or early phase or phase 2 trials at BRI sometime in the next year or so, depending upon negotiations. Keep on with the BRI website because we'll try and keep that updated. The challenge with doing lupus trials is lupus. Okay? Lupus is the great imitator. Okay? And so when you're looking at doing clinical trials, and I've been involved with these for 20 years or more now, you're lumping people who have renal disease, with skin disease, with joint disease, with blood clots, and one of the important things about the Benlysta trial was that it actually got the FDA to come on board with a pathway to get drugs through the investigative process. So now at least we know what kind of things they're looking for, so we can lump things together. One of the reasons that the rituximab trial failed was because they were too ambitious. So, and then you've got the individuality of lupus, okay? So that you have, I'm not sure whether lupus is one disease with multiple expressions because of our genetic makeup, or whether it's multiple diseases that are held together by a positive ANA. Okay. So until we have so-called personalized medicine, I'm not going to be able to tell anybody what's the best drug for any given individual. In some people, the interferon signature is really important, but maybe it's not for others. And in some people, it's the IL-2 signature may be important and not for others, okay? So it's much like our patients who have rheumatoid arthritis. Right now, currently, we have 5 different biological drugs, which are available, 5 different classes of biological drugs for patients who have rheumatoid arthritis. So if one doesn't work, you can choose another one or whatever, and you can sort of tailor treatment on the individual, and we've had much better success in that group of people. So we're a ways from that in patients with lupus. I was both at the EULAR meetings in last June in London, and I was at the ACR meetings, and the College of Rheumatology meetings in November. The only trial that I saw that was probably in phase 3 was the interferon alpha trials. We did an interferon alpha trial a couple of years ago, which was met. I don't think it went anyplace. But now there's a new drug that seems to be more efficient. So I suspect that might be a year or 2 away. Okay. There are some other combinations of things from various different medications that we're looking at, but these are basic drugs that have already been approved for other reasons. Okay. That are, but the problem in a lot of this stuff is funding. And a lot of these trials are by our drug manufacturers. God knows what's going to happen to the NIH in the upcoming budgets. I would lobby as advocates to write to your congresspeople and make sure that funding for autoimmune diseases is maintained. Okay, so that will help too. But the reason that I didn't touch on some of these things that we were talking about this is, for instance, there was a trial that looked very promising. There was a doc here by the name of Jan Hilson. I worked with Jan for a long time, and then she went into the drug industry, and she's at Bristol Myers Squibb now. And she was in charge of a drug trial called Atatacept. And that looked very, very good, and then they had a couple of deaths, so I haven't seen that drug go forward. Okay. So, things are slowly slogging along. Drug trials take a long time. I was one of the original Enbrel investigators back in the early 90s. So that's what my pedigree is, dating back, 30 years now. God, that's long. Anyway, so it's going to take a long time, I think, but I think there's still enough other medications. I mean, drugs like Celsep and whatever, now even in combination with other drugs, so that if people have really bad disease, and I think and if you look at lupus survival trials over the decades, even though I said in the past that some of the response rates, like for kidney disease, whatever, are not as robust as we would like. Survivals are much better than they were when I was first a fellow back in the 70s. So we're doing a better job of keeping people alive, okay? And that's positive news, okay? And we're making some progress. We've gone from drugs like cyclophosphamide, which would make people bald and make them sterile and drop their white count and give them cancer, whatever. We've eliminated that kind of drug. So we've made some progress. I'm not being, bleak. We're doing a much better job than we used to. And we've learned that drugs like prednisone, although they're a lifesaver, need to be minimized. So we made some good changes. But as far as blockbuster drugs coming down the pike, I would be surprised.
And it's gonna be very individualized. What we really need are people like she's doing to look at the genetics of these things and identify people and pathways, so we can target for any individual person what's the best drug, and that's called personalized medicine. And we were hoping, with the Human Genome Project, that was gonna be great. And that was the Clinton administration. So that was a long time ago for me.
Thank you. Any question in the back there?
I'd be happy to, if you just, or if you want me to, I'll just email it to you. You can give me your email address. If all of these things
Or
can
what
be,
do
we can do that. Why don't you,
review
yeah.
our,
Yeah, why don't you send it to Wilma, and Wilma just send it to anybody who wants it. We'll be happy to.
Could you repeat the question?
The question was a PowerPoint presentation. Can people steal the slides? And why not? There's nothing. And so we're happy to share them, and if you contact Wilma, she'll forward them. She has them.
Any other questions? Yeah.
So the lupus.
I'll repeat the question so people can hear, or one of my.
The trials, are you only using people with one lupus, or two, or all three, or how do you pick your lupus patient?
So it depends on the trial. The question is, how do we choose people for the trials? Okay, and any given trial has certain parameters. So they might exclude people who have had, really bad kidney disease, or if they've been on, certain medications, whatever, in a given period of time, or if they've had cancer, or whatever, or if they're childbearing, or something like that. Although that would be hard to lose patients. But you have to promise to use double modes of birth control, or whatever, if you're in one of those kind of trials. But there is a scoring system. That was one of the things that came out of the Benlysta trial, okay? And there are a couple of scoring systems that we use, which are a real pain in the posterior to do, but they're very complicated. There's one called the SLEED-I, which looks at a scoring system for various and sundry things, and there's something called the BILOG, which is a British IELTS lupus activity gauge, okay? And so you have to fill these things out. And so some of them may exclude, let's say, kidney disease, because if you've got somebody who's got really bad kidney disease, you may not want to use a drug that's not going to work, okay? There are other trials that may look for patients who have kidney disease, because in kidney disease, what's the endpoint? The endpoint is if you go on dialysis, you've got a drug that didn't work, okay? So there are various ways that we do this, and that's the drug manufacturer has a negotiation with the FDA, and they come up with what kind of people that they're looking for. The problem, as I said, in looking with doing studies with patients with lupus is there's no one patient. Everybody with lupus is different, and some people have kidney disease, some people have skin disease, some people have kidney and skin disease, some people have pleurisy, some joint pain. So there isn't a typical lupus patient. So you have to weight these trials, and in the BILOG, for instance, you get X number of points if you got kidney disease, you get less points if you have skin disease, so you have to come up with that kind of stuff. It's sticky thicket. But we're working our way through it now, and at least we have a path. Okay, so anybody is welcome to, and to ask us if you're interested in it. If you would fit the criteria, you might fit one trial, but maybe not in that trial, but the next one came along, might include that given individual. So it's to some degree, it depends upon the negotiation between who's going to fit any trials, and negotiation between the drug manufacturer and the FDA.
All right.
How do you feel about the immunotherapy, the infusions, and finding a person's overall ability?
I couldn't hear after the immuno.
How do you feel about the immunotherapy, the infusions, and finding the lupus over the course of a lifetime?
So the infusion of this is a question about the infusion of the Benlysta,
No, the immunoglobulins.
or the IVIGG infusions? Okay, so IVIGG is not something that we've talked about. So intravenous gamma globulin is, it's a pool. You go to the blood bank and you donate blood, okay? And they take the red cells and they use them for patients who need blood transfusion. They take the white cells from people who are on chemotherapy and may need white cells, and they give their platelets to people who need platelets. And all the other stuff, those are the gamma globulins and proteins, whatever, they make a pool out of that. And that can be given to people who have immune deficiencies, so we give them to kids, or people who might have HIV or whatever. Or sometimes we use it, high doses of IVIGG can also be used in patients with autoimmune diseases. And it's controversial how it works. It seems to block some of the receptors on the cells, and so they don't get turned on as much. It's a very safe thing because obviously you're not depleting the immune system, you're supplementing the immune system, okay? And so sometimes we'll use that. It's incredibly expensive. It's like $10,000 in infusion and you get it on a monthly basis.
It's gone up to $126,000.
Well, 10,000, you know, so it's a monthly, 120,000, a month?
Yeah, that's what mine was.
Okay, well, there you go, all right. So it's even more than I thought.
Yeah, it's a whole thing.
Okay. And we sometimes use that, you know, when other medications don't work, because obviously the cost of the medications is ridiculous. You know, we also use other things. There's a thing called plasmapheresis, which is something we use in patients where we're desperate. That's the thing where you take the blood out, put it through a machine like a dialysis machine, and then put it back into the patients. It gets rid of the evil humors. I have no idea what we're doing when we're taking that stuff out, but it works as rescue for some people. You know, we don't use leeches anymore. We don't use bloodletting anymore. I think that's a plasmapheresis. That would be cheaper than the plasmapheresis. So there are a lot of things that we use in desperation. You know, when again desperate situations requires desperate measures. Fortunately, those are rare instances. Very, very rare instances. I think we had a gentleman in VM that we just did IVIGG infusions for recently because he had multiple medical problems and we didn't want to immunosuppress it. But it's, you know, maybe once a year.
Oh, I did them here for every 6 weeks for well over a year.
But I'm saying it's a rare individual that we do that.
All right, there was a question that, back in
So you said for preventative measure to stop smoking, and I was just wondering, smoke marijuana or tobacco?
The question is medical marijuana versus tobacco. I don't think we know much about medical marijuana when it does to the immune system. Okay? I really don't know. I guess if I were, and I haven't since the 70s, so, you know. But I would probably do edibles if I was going to do that, okay? Simply because we know a lot of stuff turns on, in patients who are smokers, it turns on the lymphocytes in the lungs, which then talk to the other lymphocytes. And it's all the adulterants and smoke and whatever, you know. So, you know, so I would do edible stuff if you know, and I have no problem, you know, there's a lot of interest these days with cannabinoids and whatever, and what that does, and it has, you know, that, who knows what's going to happen to research on that kind of stuff with our new administration. But at the national meetings, there's actually interest in, I mean, I'd rather have somebody taking cannabinoids than opium products. You know, it's a lot easier to get addicted to OxyContin than it is to medical marijuana.
So my chocolate chip cookie is good with that?
My friend,
there was another question, Brad. Yes.
Yeah, my question is about the risk factors for family. It's a big mixture of Seattleites, some of whom have been in studies, and so their grandchildren and great-grandchildren, and some of them haven't been, and we don't know what most people are talking about. They sound like we should find out what our grandchildren's risk factor is by giving somebody some sort of blood, give your blood away and they'll tell you. Is there a way to do that?
Okay, so lupus is what we call a complex genetic disease, It means that there's many genes that each individually contribute a small amount, and it's the combination of them that increases your risk. And at this point in time, there's not a test that can tell you, what your risk is of getting lupus.
But could you tell me when, if I was somehow in a pool that could be used for some research?
I think you can participate regardless. I mean, there's studies that use healthy controls. There's studies that use first-degree relatives, meaning you have an immediate family member who has lupus, because they want to know, okay, so you have an immediate family member. We know you're at 20 times greater risk than somebody in the general population. What are some of the early changes in your immune response? You want to see what's going on before somebody actually gets lupus. But as far as, and of course for lupus patients themselves, but as far as like having a genetic test at this point, the answer is no, we don't have that.
Then why do you want people's blood tests to be, it was mentioned in your talk about if you want to do a blood sample.
Right, so what we do with the blood samples is that's where we can look at your immune cells. They're circulating in your blood. They're also called white blood cells. So by looking, getting a blood sample, we can isolate those cells and then study how they change in lupus. And that's how we understand how the immune system is malfunctioning.
So if anybody lives in Seattle, what should I tell them to do, or what could I do besides look on the internet? Because whoever pays any attention will look on the internet.
Right, well, you could talk to, I don't know where she went, what's her?
Caitlin was back there.
Caitlin, yes. So you can talk to her, and Rachel, I don't know if Hannah is here as well. She may be able to guide you to
Something besides the internet,
resources.
please.
Okay.
So, just a couple of things about risk factors as well. In addition to the fact that there's a genetic predisposition, and it's probably multiple genes that all have to line up together. Think of it playing a poker hand, so you can get like 4 spades, but if the next one is a heart, you're not going to get a flush, okay? The other thing has to do with the environment. Okay, so it's this complex interaction between the environment and the genetics, and even in twin studies, identical twins, it's about 30% of a twin will get it. Okay, I've been doing this for almost 40 years now, and in that period of time, I've seen 2 families where I've had mothers and daughters with lupus. It's extremely rare. Okay, it's extreme. I have one family with 3 generations. I take care of the grandmother, the patient, and the granddaughter, all of whom have had lupus. But that's like a wild card. And there is a group at the University of Oklahoma who actually have submitted their genetics, whatever, to them because they're looking at this kind of stuff. But in twin studies, with all of these diseases, whether it's lupus or rheumatoid arthritis, whatever, I have patients with rheumatoid arthritis where they have identical twins and they don't have it either. We also have patients where they're husband and wives. I don't think it's a sexually transmitted disease.
But everybody has advice.
Yeah, I understand. But people, parents ask me that question every day. What about my kids? Okay? And the answer is, it's this complex dance between, the environment and the genetics, and whether it's cancer or autoimmune disease or whatever. So you may have the right genetic predisposition, but if you don't get exposed to let's say you're not a smoker, you're going to lower your risk.
Lady in yellow.
Have there been studies as well as to whether if you have lupus, your children or grandchildren are more predisposed to have other autoimmune issues than the general population?
If you have one autoimmune disease, as we were talking about this before, there's a likelihood you may have a second autoimmune disease, okay? Because those genes tend to run in clusters.
I have one poor lady, she has type 1 diabetes, rheumatoid arthritis, and scleroderma. I don't want to be her child. You know. And she's done very well with all diseases with her immunotherapy. So they all tend to cluster together. And if you and they do, you know, we do see this, that, you know, one family member may have Crohn's disease and somebody else may have lupus and somebody else may have, you know, a grandmother has MS or whatever it is. You know, the same way that there are genes that seem to cluster for cancer. You know, I think that's better studied. There are certain cancer genes like the BRCA gene, you know, we know in breast cancer or whatever. But in the autoimmune things, there are still genes that are being uncovered that may also be involved. So I think we're a long way from knowing about the genetics of these diseases. Do you want to comment on that? No? Okay.
And another Sunday.
I have a question. Have there been any studies or any information out there on homeopathic, I think that's how you say it, therapy?
The question is homeopathic therapy?
Yeah.
Okay.
On lupus.
Well, I think the only one who really strongly believes in homeopathy is the Queen of England. It really has been disproven as far as that kind of stuff goes. So, you know, homeopathy, for people who are not familiar with this, is you take minuscule amounts, I mean, it's almost molecular small amounts of an agent and serially dilute it, and then you're supposed to give it back to the person and make them better. And it can't say that, I'm trying to think of not being punched or it doesn't hold water, you know. It just hasn't been shown to work for those kinds of things. Naturopathy, you know, may play a role. I'm surprised nobody's asked about, you know, what what about the anti-inflammatory diets? Okay, I'll raise that question. You want to answer?